everyone. Thank you for joining us tonight. My name is Stavroula Savellidis, and I'm the Executive Director of the Nassau County Medical Society and the Nassau Academy of Medicine. Just before we get started, just so everybody understands, everybody will be muted. If you have a question, feel free to type it into the chat box, and our speaker will be able to answer as the questions are coming in. Okay, so our guest speaker tonight is Dr. Srihari Naidu. Dr. Naidu is a professor of medicine at the New York Medical College in Valhalla, New York. He graduated from Brown University in Providence, Rhode Island, for both undergraduate and medical school as part of the 8-year program. Following this, he was a resident in New York Presbyterian Hospital Cornell Medical Center in Manhattan, and then a cardiology and interventional cardiology fellow at the University of Pennsylvania in Philadelphia. After several years as an attending at New York Presbyterian, Cornell, and NYU Winthrop, he moved to Westchester Medical Center and New York Medical College, where he runs both the Hypertrophic Cardiomyopathy National Center of Excellence and the Cardiac Catheterization Laboratories. Dr. Naidu is triple board certified in internal medicine, cardiology, and interventional cardiology, and has been featured in Westchester Magazine and on the cover of Cardiovascular Business, both of which highlighted his national role in hypertrophic cardiomyopathy, the most common cause of sudden cardiac death in athletes and a common cause of heart failure. Dr. Naidu is a pioneer in the minimally invasive alternative to open heart surgery known as alcohol septal ablation, and performs the highest volume annually of this procedure in the United States. So without further ado, I'd like to pass it over to Dr. Naidu to do his little intro, and then we'll get straight to questions.
Sure. Thanks for the intro. I'm happy to be here. I grew up on Long Island, so Nassau County Medical Society is very important to me. I see it's a 100-year anniversary. I think that's extremely impressive. A lot of medicine and cardiology started in the East Coast and in New York in particular. So there's a long heritage here of cardiovascular care and incubating really great doctors in this field. My parents live in Great Neck, and I have an office in Garden City, so I know the area pretty well. So I'm happy to be here.
Thank you. So we'll get started with the first question. Go. Ooh, sorry. When we talk about cardiovascular diseases, what exactly are the diseases we are talking about?
Yeah, so this lecture and discussion today, and I do want to make a discussion, feel free to put some questions in the chat box, is really to allow a conversation about the bread and butter heart disease that we all talk about. I'm going to go through some of the disease states, some of the colloquial terms about heart disease, so that we're all understanding things. And it's a lot about what we normally don't have as much time to talk about when we see you in the office, but really it's important to understand this before seeing your cardiologist and to understanding how to prevent heart disease going forward. So cardiovascular diseases, if you look at them all together, they're basically anything involving the heart and the vascular system. So the heart and all the arteries and veins that pump blood away from the heart and back to the heart. And it involves, to some extent, the lungs, because the lungs have to bring oxygen in and oxygenate the blood. So anything that can affect that system is called cardiovascular disease. If you add the lungs in, it's called cardiopulmonary disease. So you can divide those two things up into heart problems and vascular problems. If you look at heart problems, by far the most common thing we think about is, in terms of the bucket of heart disease, would be heart attack. So somebody who has a problem with blood flow to one of the arteries of the heart, and the heart gets starved of oxygen, and a portion of the heart muscle then begins to die. And that's called a heart attack. And we'll talk a little bit more about the treatments of heart attack later on, but it can lead someone to have a low heart function, which is the second big disease in heart disease that we talk about, which is called heart failure. So people get scared of the term heart failure, but what it really means, it doesn't really mean that your heart has failed, that it's gone and you have to have a transplant. What it typically means is any gradation of inability of the heart to pump blood properly compared to what the body really needs. So you may have a mild heart failure dysfunction that doesn't allow you to run, but it allows you to do everything in your daily life, including climb stairs and go shopping. And yeah, that's a form of heart failure, but it's not as concerning or as scary as somebody who had a massive heart attack, a large part of the heart not working, and they can barely sit up or stand without passing out or being short of breath. So there's gradation. So the second point I want people to understand is that if your doctor says you have congestive heart failure or that you have heart failure, please don't think that as a death sentence or something that is irreversible. In many cases, we can improve that to the point that people can live a normal life and feel perfectly normal. So that's the other bucket of heart disease called heart failure. And heart failure can be from the muscle not working well, or it can be from any other structure in the heart, such as the valves. The valves are a key one because we have ways of treating the valves today. You may have heard of TAVR or valve replacements, or leaky valves or mitral valve prolapse that could be fixed with what's called minimally invasive or procedures that are done through the groin or through the skin. These are all areas of rapid development and innovation in our field, so that a lot of patients don't need to have open heart surgery. They can have other types of therapies to fix a leaky valve, for example, or fix a tight valve, for example. But all these things cause heart failure. We'll talk a little bit more about that, but lots of things can cause heart failure, including electrical problems or problems with the lining of the heart, or even massive things such as clots. You can have a big clot that goes from your leg all the way through the heart to the lungs. And if the lungs get flooded with clots, that's called a pulmonary embolism. You may have heard of that. That also doesn't allow blood to flow out of the heart into the lungs and back to the heart again. And that's a form of heart failure too, or it could be. The next big bucket of heart disease that we talk about is really a vascular problem, and that would be stroke. So whereas heart attack and heart disease is the number one killer or number one thing that hurts people as they get older and is the limiting part of life expectancy in this country still, stroke is still up there as either 2 or number 3, and then the other one is obviously cancer. So heart and vascular disease take up 2 of the 3 top reasons why people ultimately die in developed countries. Now, stroke can happen for a number of reasons, but it's clearly a vascular problem, meaning that there's a problem with blood flow to the brain. And if the brain doesn't get blood flow, you'll have symptoms. We'll talk more about that later. And they're usually pretty dramatic. And then there's ways to both treat the problem in the brain, treat the clot in the brain. And then after you fix that, you then have to go hunting to see why did it happen and can you prevent it from happening again. The most important consideration after a stroke, in addition to rehabilitation, getting you back on your feet, is why did it happen and can you prevent it from happening again? So stroke is a big one. And then the last one I'll bring up, because it's becoming very common in our America, is an arrhythmia called atrial fibrillation. So I think as people have gotten older, and in a way it's good that we've been able to treat heart failure, we've been able to fix heart attacks and get people back on their feet, back home with their families. People are living longer, and they're living longer with a control of their heart disease so that they feel and do well. But as you get older, there are other diseases that come, and one of them is this rhythm problem called atrial fibrillation. We're going to dive deeper into each of these in a little bit, but that's an arrhythmia that can also cause stroke. And so it's interwoven into the whole stroke issue and also into the heart failure issue, because it can also cause heart failure. And so those are the 4 main categories of heart disease. I guess the last one we can touch upon is that some people will have pure vascular disease, meaning that the vessels in their legs may get blocked up. That's called peripheral vascular disease. Typically happens in smokers or people with diabetes. In fact, if you don't have smoking, if you never smoke really and you don't have diabetes, it almost won't happen. But these people who do smoke, or if they have diabetes that's been hard to control, the blood vessels in their legs get blocked up, and that causes changes of skin in their legs, meaning and the skin gets thinner, and they may start getting ulcers in their legs. And these are the people that are in jeopardy of amputations. We certainly don't want that to happen, and so it's very important to talk about vascular disease, definitely controlling diabetes and smoking, and then doing all the things to control risk factors, as we'll get into. So a lot of heart disease we focus on has been how to treat it once you have it. But I'm going to spend a good amount of time during this next 45 minutes or so talking about all the risk factors, because certainly if you're younger and you don't have these things, you want to do as much as you can to minimize your risk of developing these. Because once you have it, we have a lot of good treatments, but it's always better to prevent than to treat. So we'll focus some time about that.
Which leads us to, what are the risk factors for cardiovascular disease? How do they damage the heart? And what can we do to minimize them?
Yeah, so this is the crux of what I want to talk about in this next 10 minutes or so. So there's lots of things that we know promote problems with the vasculature in the heart that result ultimately in a heart attack or heart disease, as I just described it, or vascular disease or stroke. So if you go through them one by one, the first one we should talk about is tobacco use. I'm going to put them in order of things you can control. Tobacco use is something you can control because it is obviously an addiction, and I'm not saying it's easy to stop. It's certainly easier to not start, but once you've started and you are somewhat addicted to it, it's important to stop. And here's what smoking does. Smoking essentially damages your blood vessels. It attacks them, it creates an inflammatory state that attacks the what's called the endothelial cells of your blood vessels. This results in a situation where those cells no longer form a barrier between the blood and your vessel wall. Well, that's a problem because if it's not a barrier, then guess what starts going into the blood vessel wall is cholesterol. And cholesterol starts developing in there as plaques that are even seen in 20 and 30-year-olds. But as you get older, if you have a lot of cholesterol and you keep damaging the arteries, the cholesterol builds up in there. And if it builds up to the point where it's obstructing blood flow, that's what leads to all the problem. That's what's called atherosclerosis. And if you have a lot of that, then it eventually will cause heart attack, stroke, and vascular disease. So smoking cessation is very important also because it affects the lungs. The lungs get damaged, and it is surprising that some people can smoke a long time and not notice anything. Other people smoke relatively shorter duration, maybe 10 or 15 years, and they have a lot more damage. So some of this is genetic, but the truth is, if you don't smoke, you're not going to get things like COPD or chronic bronchitis, emphysema. And people have to remember that we have some redundancy in our body. The lungs, the kidneys, the heart, all these organs are built to be able to have more than enough function to supply to do their job for the body. But as you start damaging these organs, so say for example, you damage your lungs slowly to the point that 30% is damaged. Well, guess what? Most people don't notice that. However, if you're 30% damaged and then you have a heart attack and then some of the blood backs up because it can't go forward, so now you have a 30% damaged lung that's now drowning in blood, well, guess what? All of a sudden that goes to 60% damage and now you can't breathe. So the reason we really want people to stop smoking is because you want to keep your lungs in as good a shape as possible. That way, if the dominoes start falling one by one and things have a problem, then at least you have some organs that are working quite well and can make up for the fact that some organs are now having trouble. So what we don't want to see is that everything in the body is 20, 30% damaged, because then you don't have a lot of reserve when things get worse later in life, or if one thing happens that you can't completely control. So tobacco damages the lungs over time and can churn up the arteries to create blockages. And in addition, one of the problems with smoking is that it creates a very unpredictable state. A lot of the medications we have for heart disease or after a heart attack, for example, we may put a stent in you, we may put you on certain blood thinners, and we may control your diabetes. We may put you on a good diet and exercise routine. And we can tell you, based on studies that we have, that if you do all those things after a heart attack, you probably won't have any problems for the next 5 to 10 years. However, people who smoke, we can't be as predictable in terms of how they'll do. In all the clinical trials, people who don't smoke are in those trials. If you're a smoker, you're not in these clinical trials. And so we know that people who don't smoke do quite well, but people who smoke, it creates a very unpredictable situation, because the smoking does one last thing that we should talk about, which is it makes your blood more likely to form clots. And if that happens, then all of a sudden, things can be very unpredictable. A minor blockage can all of a sudden erupt, and then the clotting cascade becomes uncontrollable and just forms a complete clot that causes another heart attack. So the first thing I tell my patients to do if they're smokers is to stop smoking. And it's important to find a physician who can help you do that. There's lots of ways to do that these days. But bottom line, it comes down to your family and yourself getting behind the idea that we want to do this so that you minimize your risk to your lungs and your heart going forward. And then there are medications and other ways to both chemical and behavioral therapy to try to get you off the cigarettes. It's important to realize that the amount matters. If you can go down from 2 packs a day to 1 pack a day, 1 pack a day to half a pack a day, half a pack a day to 2 cigarettes a day, it does matter. It does help to even go down, and then of course ultimately to get rid of it. So tobacco use is the most important one, and I'm very tough on my patients about that. But I'm the kind of tough where I'm still with you. I'm on your side to do it, and I'm not abandoning you. That's important for patients to know that there's someone who wants them to come off their cigarettes, but will be there for them. The second one is hypertension, so high blood pressure. So high blood pressure happens as people get older for a number of reasons. Some people tend to retain salt, and salt causes high blood pressure in those people, but not in other people. So in some people, they have a higher vascular tone from adrenaline and other stressors. And in other people, they have an activation of some of the hormones in the body, something called the renin-angiotensin system, which is a system of hormones that increases the vascular tone, meaning it makes the arteries more spastic. And if the arteries are tense, any given blood in it will be at a higher pressure, Just like if you have smaller pipes in your house, smaller diameter pipes with the same water pressure, the same amount of water in there, the pressure is going to go up. It's pretty simple. So you have to do one of those things to decrease the blood pressure. One thing would be to decrease the salt. So we oftentimes tell people to have a salt-free diet or a low-salt diet. It turns out that it tends to be more in African Americans and Hispanics that retain salt. And Caucasians and Asians tend to have a higher revved up renin system and stress system. We don't know why we've all developed this way, but it's been very good to know those things because we don't want to give a medication that's not that effective to the wrong person. And some of it is definitely genetic. There are certain medications that we can give to Hispanics and Blacks that work much better than they would work in Caucasians, and vice versa. And so that's very important to know. So you might want to get rid of salt, and that's where we use diuretics like Lasix or hydrochlorothiazide or Demodex or chlorthalidone, things like that. Those sound familiar to you. In other people, we may use a class of medications called beta blockers. These are the people who the stress response is higher. And what it does is it decreases your heart rate, it decreases your blood pressure by decreasing the strength and contraction of your heart muscle, so it's not squeezing so much blood out each beat. And then in other people, we use what's called calcium blockers. These may be verapamil or diltiazem, and these basically relax the blood vessels. They tell the muscle in the blood vessels to not squeeze as hard, and so the pipes get bigger, allowing the blood pressure to drop. Okay. And there's other ones that allow blood to pool a little bit in your legs. These are called Norvasc or amlodipine, and that decreases the blood to the heart a little bit, just enough so that the blood pressure goes down a little bit. So these are the different blood pressure medications that we use, and we'll oftentimes pick one of the classes based on, what else you need. There might be some other disease process you have that needs a beta blocker, so we'll choose that. Or there might be some other, you may have a little swelling in your legs, so we might use a diuretic. But we may do things that kill two birds with one stone, so to speak, and get you on the least number of medications to control your blood pressure. The blood pressure causes a problem because it also damages the arteries, okay, just like smoking. The third thing is diabetes. And diabetes is an epidemic in this country. It is tracked very much with obesity or being overweight. And that's because people who are overweight or obese tend to have trouble with something called insulin resistance. That means that they don't respond to insulin as well. Insulin is the hormone in your body that tells sugar to get out of the blood. And if you're overweight, that hormone doesn't work as well. And so the sugar rises in your blood, and over time, it goes higher and higher. And if it gets higher, it also damages the blood vessels. It also causes inflammation throughout your body, and it also causes the blood to be sticky with each other, clotting. And that all causes a lot of blockages as well as heart attacks in patients. So diabetes is a big one, but the biggest way to control it is maintaining an ideal body weight and maintaining a proper diet, which you can talk about a little bit later. Again, these are hard hurdles to do, but it is the way to do it. And you always have to try and keep going in that direction. Whether you're successful is almost irrelevant. It's just part and parcel to a proper therapy, including medication. And then, of course, there are medications to control the sugar and push it back into the vessels or into the body or out the system. Other risk factors include cholesterol. So cholesterol is something we can modify easily because we have medications for it. And part of the reason why we're so hard on people about using what's called statins like Lipitor or Crestor is because of all these things I'm mentioning to you, quitting smoking and keeping your cholesterol down are things that we can do fairly quickly within a few weeks to months. So these medications really push down the cholesterol levels tremendously. And if you remember, the reason why people develop atherosclerosis or blockages is that the cholesterol gets into the blood vessel wall because it's damaged by high blood pressure or smoking or diabetes. So the beauty of having low cholesterol is that even if the blood vessel wall gets damaged, there isn't that much cholesterol around to get into the blood vessel wall. The last thing I'll say about cholesterol is that some people are thin, no diabetes, no nothing, and they have high cholesterol. That's because there's two ways to get cholesterol in your body. One is you eat foods high in cholesterol, and two is that the liver actually makes cholesterol. And so some people genetically are just prone to making a lot of cholesterol. We don't know why. Throughout the generations, their family makes a lot of cholesterol. So the only way to get rid of that is to use the medication. If you're thin, in perfect shape, exercising all the time, and your cholesterol is still high, that means your body's just producing it. And that cholesterol is just as dangerous as the one you consume. And so you're going to need medications. All the exercise in the world is not going to lower that cholesterol at that point. And then the last things we can talk about later is diet and exercise. Exercise definitely helps lower blood pressure, probably at least by 10 points, by keeping the arteries nice and flexible and healthy. And diet, by keeping your ideal body weight, you can drop your blood pressure 10, 20 points just by maintaining weight loss. Now, you don't always have to be ideal body weight. If you just lose 20, 10, let's say you're 250, you lose to 220, that may be enough. That may get your pressure down to the point that you don't need medication. And I will always try that. And in fact, if patients do well on medications and then they lose weight, oftentimes they don't need as much medications. Their pressure is low, they start getting dizzy, and their cholesterol is low, and you can come off the medications. Nothing's more satisfying than having somebody start with medication, stop the smoking, and then they start losing weight, and then you don't need the medications and you can come off. So you can reverse a lot of these things because the body was not meant to need the medications most of the time. It's just that we've let our bodies get to a point where we need them, and then that all is not lost if you come back and you can get your body back in shape. So those are the main risk factors and what we can do to minimize them. We can talk more in the chat if there are questions.
How is a heart attack recognized and treated?
So this is important because this is the #1 killer in our country. And, you know, one of the issues is that people are living into their 80s now. Life expectancy is into the 80s. People are 83, 84 years old, which is the average age of death. And, you know, we all want to live forever, but don't forget that about 100 years ago, the life expectancy was probably about 50, 45 or 50. All of that change has been because of technology, really. Because of the way we treat heart attacks, because of the way we can treat cancer right now, because of the way we can monitor and treat strokes right now, this is all allowing people to live a lot longer, and our emphasis on diet and exercise as well. But a heart attack needs to be recognized, both heart attack and stroke, because if you don't take care of it within the first hour or two, if you don't come into the hospital, then the damage is already done. The brain and the heart are really the only two organs, two important organs, where if you damage it, whatever's damaged is done. It doesn't come back, it doesn't grow back, it doesn't regenerate. The rest of the muscle or the rest of the brain has to pick up the slack. In the case of the brain, it can pick up the slack, but if you damage an area that handles your right hand, it's going to be very hard to get your right hand handled again. It can work around a little bit, but not perfectly. So stroke is almost something that you can rehab from it, but it's rare to get it all the way back. Heart attack is very similar. You can damage a piece of the muscle, but usually there's other muscle enough to get people to have a normal function and not go into heart failure. The only caveat to that is you can damage parts of the heart muscle that affect valve function. So if you affect the part of the muscle that is attaching the valve, which is the door, then the door is going to be leaky. And so you can have heart attacks that have more lasting damage because of that. So to recognize a heart attack, we always think about chest pain, but I'll tell you that most people who come in, they're not screaming in pain. They're not saying, oh my God, it's so much pain. They're saying, I have a dull ache, I have a pressure sensation. Usually it's in the center of the chest. Sometimes it goes up to the jaw. Typically, if it's chest pain that goes up to the jaw and it hurts in your jaw here, that's almost always heart attack pain. So don't just ignore it thinking that you may have slept funny or something like that. Heart pain will sometimes go to the left arm and down the arm. It never goes to the right arm, it seems, but it usually is central in the chest, goes up to the jaw, and sometimes down the left arm. But you don't have to have all those things, okay? And it doesn't have to be a lot of pain. Sometimes it may go into your back. What it definitely is not is people don't say it hurts right here. If you can point to one spot on your chest and say that's where it hurts, that's not going to be heart pain. And that's because heart pain is more dull. You can't usually figure out where exactly it is. It's kind of all over in the chest. Okay, so if you can pinpoint to one finger, it's never heart pain. Okay. The other thing is if the pain is worse when you take a deep breath in, if you take a deep breath in and it hurts, and you kind of catch yourself and you find yourself taking shallow breaths because it feels better to do that, that's probably not heart pain too. The heart doesn't care if you're breathing deeply or not. It's too internal to know those things. Okay. But if you're having chest pain and you're not sure, I wouldn't say look at those things and don't go to the hospital. If you're not sure, it's easy enough to call 911. And I will say that if you think you're having chest pain and you're not sure, 911 is the way to go. There's been lots of studies that if you call your doctor, you call your friend who's a doctor or a friend who's a nurse and say, oh, I'm having this, I'm not sure, you're wasting time. And it's very clear that if you track we've done this, where you track all the heart attack patients and you looked at what they did before coming in. The ones who went to some other place, they went to their doctor, they called this or that, they called their mom, they called their spouse, they called other people, they did worse. They died more and they had larger heart attacks because they wasted time. It's better to call 911, then you can call someone. And then let 911 come take you. Don't be difficult. Come right to the hospital. The beauty of calling 911 is you go right through the ER. You don't have to wait in triage. You basically come right to a day. And because it's chest pain, they'll do an EKG in 5 minutes. And if it's okay, then it's a false alarm. They'll probably keep you for a couple hours just to make sure it's not a real heart attack and send you home and find a cardiologist or an internist. It's much safer to do that because if you miss it and it becomes a real big heart attack, it is harder to fix you in the hospital. So to recognize that I just went through, and then how it's treated basically is really only treated in the hospital. We did notice during COVID last year that we saw a big drop off in heart attacks in the hospital. But what we saw instead was a big increase in the amount of people unfortunately found dead at home. And so this was reported by the fire department in New York that there was a huge spike of people just found dead at home. They didn't have COVID. What they had was scared to come into the hospital. So they stayed at home and they had their heart attack and died, or they had their stroke and died. So it's very clear to us as physicians who take care of heart attack patients who are doing this routinely, that what we're doing really matters, because if we stop doing it because COVID or just stop doing it, people are dying at home. And so we got to keep doing this. And so if you have those symptoms, you got to come in. And the way we treat it is, let's say you come in, you have chest pain, they do what's called an EKG, as you may know, or little dots on the chest, and they print out this readout, and we can tell from there what part of the heart is in jeopardy. If it looks like it's a heart attack, you get rushed up to something called the cardiac cath lab. The cardiac cath lab is an area where there's nurses and technologists and fellows in training and attending physicians such as myself. We very rapidly, within 90 minutes from you hitting the door, open up the artery. We do this usually from your wrist or from your top of the right leg. We thread catheters up to the heart. We look to see where the blockage is, which is under X-ray. You're awake the whole time. We give you some sedation perhaps, but really we want to quickly do this. We get into the artery through the leg or through the wrist. You won't feel us getting into the heart. And then as soon as we open up the artery, your pain will go away, typically. Now, some people, if they come to us late and they have a huge heart attack, can be very sick, but I would say 90–95% of people who come in with a heart attack now, we quote unquote fix the artery, and you go into the intensive care unit for a day or two, and then you're usually home within 2 or 3 days. And we try to see, how much was damaged, what's left, and we can give you a prognosis of, okay, this is just a wake-up call, for example, and then let's go over the risk factors and get you back on track, stop the smoking, get the diabetes under control. Or if it's a larger one, then we talk to you about, how you may have to live with heart failure to some extent and modify your routine and try to get you in best shape as possible. But the reason I'm in this field and running a cardiac cath lab is because most people do quite well. But a lot of it's on the patient. If you don't come in, we can't help you. But if you do come in, cardiology is really, really good at getting you home to your family. So that's how we treat it nowadays.
How's a stroke recognized and treated?
Yes, this is the other big one. And the reason, again, that these are important is because, just like time is muscle for heart disease, meaning that the longer you wait, the more muscle is being killed or infarcted, as we call it. Same thing is true for the brain. So if you're having a stroke, we need to fix that within 1 hour to 3 hours maximum. Okay, after that, it's irreversible and too late. Now, the beauty of a stroke, if there is beauty in a stroke, is that it's usually much more recognizable because you may be trying to walk and you can't walk, or you may be trying to speak and you can't speak. And then the person looks at you and saying, how come you're talking gibberish? It's just usually it's much more obvious when you have a relatively large stroke. You fall, you can't move a whole side of the body. You freak out, because we would all freak out in that situation. And of course, we're going to call 911. So the good thing about a stroke in that way is that as soon as it happens, people typically do call 911 and come right in. So when they do come in, most hospitals will do a stroke code, which is basically an overhead. So neurology will come see you, just like in the heart attack. It's a STEMI code, or ST elevation MI, that's what we call it, heart attack. And people come down to see if it's a real heart attack. For this, they come down to see if it's a real stroke. It'll be obvious to some extent if you can't move or you can't speak. They'll do a quick neurologic evaluation to see how bad things are. And then they'll be rushed to a CAT scan. So they'll do a quick CAT scan of your head to make sure there's no bleeding in the brain. So quickly, there's 2 types of stroke. There's a bleed, where you bleed into your brain. That's rare, but typically pretty devastating. But fortunately, it's rare. It's a minority of strokes. The majority of strokes are what's called ischemic strokes, meaning that a plaque or a clot traveled up the blood vessels and got lodged in a vessel in your brain and doesn't allow one spot of your brain to get blood flow. That part of the brain, depending on what it affects, if it affects your speech, or it affects your arm, or it affects your leg, that part won't be able to work during that time. So then the treatment really is either blood thinners to break up that clot. So we use something called TPA or thrombolytics, which is basically very, very aggressive blood thinners that tell all the clots in your body to go away, okay, for timing. That doesn't mean you're at a little bit of risk of bleeding during that time, but on the flip side, you're having an area of massive stroke or an area of clot, so that clot gets busted. So it'll be what we call a clot buster. It's given in the vein over about half an hour or so, okay? And basically that will dissolve the clot. And then typically, pretty dramatically in most people, if they came soon enough, all of a sudden that function will come back. If they couldn't speak, they'll speak. If they can't move the right arm, it will start getting better. But the most important part is that the chances of recovery and those medications working is highest in the first hour of you having symptoms of a stroke, and goes down by second hour, third hour. Within the first 3 hours, it really typically works. After 3 hours, then it doesn't work as well. And because it's a blood thinner, the longer you go, the more that it's less likely to work and more likely that it's just going to cause more bleeding. So that's why, again, it's very important to come in. The other ways to treat it nowadays, and we do this at Westchester Medical Center, not all places do this, is they go up with catheters and they pull the clot out. That's done by neurosurgeons or done by neurologists, sometimes by interventional cardiologists. Again, they go from the leg, they thread tiny catheters up. Instead of pushing through blockages in the heart, they push through blockages and pull them out from the brain. And that's actually been shown, especially for larger clots, to really be a lifesaver and get people back to much better function. So not that you always have a choice where to go, but the major centers can do this now. Smaller centers are stuck with the clot busters, which are good, but they have a risk of bleeding. And major centers like Westchester Medical Center, stroke centers. So you should see which places are stroke centers, for example, or cardiac centers, for example, because they have all the tricks and they're better at doing that. So that's where the field has evolved. If you look at the causes of stroke, it's the same causes of heart attack: high blood pressure, diabetes, smoking, cholesterol. In addition, people may develop blockages in their arteries in the neck. That's called carotid disease. And so every once in a while, if you have any bruits or murmurs in the neck, they may do ultrasounds in your neck to see how much blockage there is. Strokes can also come from the arrhythmia we called atrial fibrillation, and we'll talk about that in a little bit. But I'll get more involved in that as we go by.
And our next one. What is atrial fibrillation?
Yeah.
Why is it important?
Yeah. All right. I think this is the last question, and then we can see if people have any other questions. We're doing pretty well on time, I think. So atrial fibrillation, I put in here because I think it's becoming an epidemic. People are older, which is good, but now they have this arrhythmia. So atrial fibrillation is something that you may feel or you may not feel. Some people are asymptomatic. They have it and they don't know it. What it is typically any stress on the heart, either heart failure, a heart attack, high blood pressure, almost anything, as time goes by, can cause a stretching of the top chamber of the heart. The top chamber of the heart is called the atria. The bottom chamber is called the ventricle. When the atria gets stretched, it tends to trigger a situation where multiple areas may start beating. And if they all start beating together and they're not controlled by your brain anymore, it's called atrial fibrillation. And then when that happens, not all the beats go to the bottom chamber. And so some of them get through, some of them don't get through. So it ends up being what's called an irregular heartbeat. Instead of having a heartbeat where you can predict where each beat is, it's kind of like you can't predict when the next beat is coming. So that's atrial fibrillation. That's what's called an irregular heartbeat. There are other types of irregular heartbeat, but this is the more important one because when the atria are fibrillating or are beating not in unison anymore, it doesn't create a situation where all the blood can be emptied properly. And when that happens, then blood kind of comes into that chamber from the lungs, and before it dumps into the ventricle, the bottom chamber, kind of just slurs around and stagnates in there. And when blood stagnates, it can cause clots to form. And if clots form in your heart, and then they leave the heart, guess where they go? Typically to the brain, and they can be very big clots. So atrial fibrillation is a problem because they are probably the most common cause of major stroke as you get older, meaning massive strokes that could kill you, or strokes that could cause major debilitation where you're in a wheelchair for the rest of your life. So it's very important to identify that people are having atrial fibrillation, especially because some people have it and don't know it. because they can have it and the rate is not so fast, so they don't notice it. Not everybody feels what's going on in their heart. Some people do all the time. They're more sensitive to it, and other people don't feel it at all. And so it is scary to know that you might be having this. And so as cardiologists, we may, if we're suspicious, we may do monitors where we put a monitor on you for 30 days or for a week to make sure you're not having it. Because the only way to treat a stroke from this is to prevent it, really. And so because they're so big, it's far more important to prevent the stroke, which means people are on blood thinners. So you may have heard of blood thinners called Coumadin or warfarin. Those are the medications we've been using for many, many years. Now we have a class of medication called DOACs, which are the Eliquis or the Xarelto or the Pradaxa. These medications are much easier to take because they're once or twice a day. You don't have to get monitored, whereas Coumadin and warfarin have to get monitored with what's called INR checks every week or 2 weeks or monthly. And so once you're on those blood thinners, then guess what? Your risk of stroke goes down to a normal person. So it's more important to identify that you have it, then get on the right blood thinners for it. And then after that, we can work on trying to get the atrial fibrillation to go away. It tends to be an uphill battle in older people because as you get older, it tends to just be more common to happen. So the most important thing is to prevent stroke from happening from it. So that's why atrial fibrillation is important. But in addition, if you have some heart dysfunction, let's say you have a heart attack and so your heart is maybe 20% down, but you don't notice it. If you get atrial fibrillation on top of that as you get older, then all of a sudden your heart function may be 40% down. Atrial fibrillation hurts people because that top chamber, believe it or not, is important. If it doesn't work properly, then it doesn't fill the bottom chamber properly. So if the bottom chamber is already a little bit weak from a heart attack or from high blood pressure or a valve problem, and then you get atrial fibrillation later in life, you may go from feeling fine to all of a sudden having heart failure. So it is important to find atrial fibrillation, treat it, and also prevent stroke. And there's a whole group of cardiologists called electrophysiologists who basically deal with atrial fibrillation, other arrhythmias, pacemakers, and something called defibrillators, which are basically shock boxes. So that's what atrial fibrillation is. I think those were our main questions, right?
Yes. Yes.
So I don't know if there's any questions or chat. Otherwise, we can talk about, kind of the way I take care of people in terms of their diet and exercise. I don't know if you had any questions.
Nothing in the chat yet. So if you'd like to.
Sure. So yeah, let's do that. And then, the beauty of this is that the webinar will be available afterwards. So we can do those two topics and then we can call it a day and then we can certainly send it around. And obviously, my email or the way to contact me can be placed up so that people understand that and can reach out if needed. And there's tons of cardiologists all over the New York area. I'm happy to hook people up with people that they might need. We're going to prefer the Nassau County area because that's where this is. So. All right, so let's talk about diet and exercise. So diet. So people get confused and about diet because there's so much in the media about what's the best diet to use to lose weight, and there's all these gimmicks that people are looking for, quick ways to do it, medications that can help it. I think the biggest lesson for diet and maintaining body weight is that it's not an easy process and it's not going to happen overnight. If it took you 20, 30 years to become overweight, it's not going to go away in 1 or 2 years even. You're going to have to spend the time, but the reward is there. So in terms of diet, people tend to focus on eating this or eating that or this kind of regimen. The most important thing first, in my mind, is to do what you need to do to reduce your weight, okay? That typically means that the balance between the amount of energy you expend in exercise or activity has to be higher than the amount that you're bringing in calorie content. So it's simple math. You have to increase the exercise you do, typically more cardio, but to be honest, weightlifting helps a lot because muscles tend to be much more burning of basal metabolic energy. And so if you maintain good muscle mass and you exercise some cardio, you're going to maintain a higher metabolism longer in life. One thing that people forget is that as you get older, your metabolism goes down. And so you burn less calories just sitting around than you did when you were 10 or 15. And so you have to make up for that. That's why these little old ladies eat like 2 saltines and they're full. Because as you get older, you're not burning anything just sitting around anymore. And so you don't use as much calories. Our problem is our brains still keep thinking that they need to have the same amount of food our entire life. But the truth is, you probably need 1/3 the amount of food at age 85 as you did when you were 25, okay? So this whole how many calories per day, it's like we have one standard of 2,000 calorie diet, That's certainly not what you should be eating at 85, but it's probably not as enough as you should be eating when you're 25 playing basketball. So that's one of the problems. So as you get older, you have to get a sense of what you've been eating to maintain your weight, right? So if your weight's been stable, then you're eating the exact amount of calories as you burn. So all you got to do is decrease the total amount of calories by even 10%. So it doesn't mean you go from 3,000 to 2,000. You may have to go from 3,000 to 2,700. And that'll technically reduce your body weight. And it's much more doable than starving yourself, right? All you have to do is decrease a little bit. So what I tell people is, I don't know about you guys, but most people know exactly how much of a portion they usually have. So they have the same kind of food every week, and they know that they have this amount of ravioli or this amount of whatever. So I tell people to keep filling your plate the same way you always do, but you always leave something behind on the plate. Leave 20% behind. Then you know, and don't go back for more. Then you know that you're eating less that week. It's just very obvious you're eating less because you've given up something. The other way to give up something small is if you typically have 3 cans of Coke in the week, get rid of the cans of Coke and switch it to water. If everything else is left the same, you're going to lose weight. So the first thing is to lose weight. So if you lose 10, 20 pounds, that's a huge difference. You don't have to always go down to your ideal body weight. Then on top of that, once you get down to closer to the ideal body weight, then you can do things like looking at the composition of what you're eating. Well, now within the 2,000 calories that I'm eating, how can I make better choices? Because once you do, so the first thing is getting rid of the weight, because the weight turns up the blood pressure, increases the diabetes, causes a lot of other problems that together just reducing weight makes a big difference. Then you do the composition. Then you say, oh, in terms of 2,000 calories, well, it's probably better for me to eat lean meat or seafood and olive oil and nuts and these things and decrease some of the fast food and that stuff, even though the total calories are the same, because now I'm going to eat a healthier amount of those calories, okay? And again, you don't want to do it all of a sudden. You can't just all of a sudden go to the Mediterranean diet or go to the keto diet. You basically have to sort of take some low-hanging fruit at each stage. And so if you look at it as more of a process over time, the reason to do it that way is you have to change your diet in amounts that you can handle. So so that you master something and then you move on to the next thing. You can't try to master something that's way too hard. You would never all of a sudden try to do a marathon. No, you would slowly gear up to it. You might do half a mile, then a mile, then after a few months you do 5 miles. And so the same thing with this. You have to give yourself things that you can actually do in the course of a month or two and then master that, and then do something else, adding to that and something else. And then eventually you're at a point where before you know it, you've done a lot of achievements in your diet and your body weight is much closer to where you want it to be because you've done it in sizes that you were able to find success in. So that's kind of how I teach my patients how to do it, and I'm with them the whole way and try to get them to be fit as much as possible. And so I think that's kind of my thing on diet and exercise.
We have a couple of questions. Any new developments in the treatment of hypertrophic obstructive cardiomyopathy?
Oh yeah, there must be somebody who knows me. So we didn't talk about that because I know I do all these fancy things with some of the more rare diseases. Yeah, there is. So hypertrophic cardiomyopathy, since we have a little time, is basically an area that I've spent the last 20 years dealing with and working with. We write a textbook on that, and I run a large center, probably one of the top 10 centers in the country for that. It's a relatively rare disease. It's a disease of the heart muscle. Where people know it is it's the most common cause of sudden cardiac death in athletes. So when people die suddenly, or a young person, 18-year-old playing basketball, all of a sudden, passes out, God forbid, dies, or just has a rude awakening and comes back. If they do an evaluation, most of these people, these athletes, have something called hypertrophic cardiomyopathy. It's basically a muscle problem where the muscle gets too thick, and that thickening of the muscle can cause arrhythmias that can be life-threatening, or over time it can cause worsening of heart failure. So the main things that are happening in the field are there are a couple new medications that are in the pipeline, neither one of which are approved, but we're doing a study of one of them called mavacamten. This is a medication that tells the heart not to squeeze as hard. The problem with hypertrophic cardiomyopathy is the muscle is too thick and too strong, and it basically almost collapses on itself and doesn't let all the blood out. So the treatment is to relax it. And so there's a medication, as I just mentioned, that can do that, still in clinical trials. So that's what we're mostly hoping for, because if that doesn't work, then patients need open heart surgery or certain procedures that I do called alcohol septal ablation, which work quite well. But of course, if we have medications that allow you to not need those things, they're probably good to have in your back pocket for patients who are higher risk for those procedures. Now, the only thing to remember is that for that disease, those medications seem to work. They may not work as permanently. They work while you take it. They're not going to work if you don't take the medication. So the beauty of surgery or alcohol ablation is that it's sort of a more permanent fix of the problem. But in general, we always try to use medications before we do risky things like major procedures. So it is good that those are coming. And if anybody is listening and has that disease, there are two main centers in New York, ours in NYU, and I would encourage you to go to either one of them. Obviously, I have a preference for my own, but they are both centers of excellence. So you should go to any center of excellence in the country for that. That's certified by the Hypertrophic Cardiomyopathy Association, and you get the best care for it. So.
Thank you. Can you address Tachybrady syndrome?
Yeah, Tachybrady syndrome is basically when the heart sometimes goes too fast and sometimes goes too slow. The reason why that's a problem is A, you don't feel well when it goes too fast and too slow and you may pass out. But our treatment for heart rhythms that are too fast is to use medications that make the heart rate slow. And so if you have a problem where the heart goes too fast and sometimes too slow, well, then those medications are going to make the slow part even slower. So typically, if you have Tachybrady syndrome, you need a pacemaker. So you need a pacemaker to prevent the heart from going too slow. And then you use medications to prevent it from going too fast. The most common causes of tachybrady are the atrial fibrillation, as I mentioned. So if people have atrial fibrillation, they tend to go very fast when they're in atrial fibrillation. And then if they go back to normal rhythm, they may go very slow. And that's because we use all these medications like beta blockers or calcium blockers that slow the heart rate down in atrial fibrillation. But then if you flip into normal rhythm, now your heart rate's 40. And you're going to be very tired, or if it abruptly goes from 140 to 40, you may pass out. So what we end up doing is putting a pacemaker in and then using medications to keep your heart rate 80. And so if it drops to 60, between 80 and 60, you're not going to feel a difference. You won't pass out and you won't feel it's too fast. So that's how we take care of Tachybrady syndrome. Obviously, you don't want to have these things and you don't want to have a pacemaker, but if you have Tachybrady syndrome, pretty much pacemaker plus medications are the treatment.
Watchmen procedure, please discuss pro, con.
Yeah. So I do Watchmen procedures. I do several procedures for stroke, one of which is Watchmen and one of which is something called PFO closure. So I'm just looking at the time. We have a few minutes to talk about it. There are treatments to prevent stroke. We haven't talked about that. So we talked about medications to prevent stroke, which are blood thinners. We talked about risk factor reduction to decrease atherosclerosis that can cause blockages in stroke. But there are procedures that can do it. So if you have atrial fibrillation, the stroke typically happens by blood pooling in the atrium, as we talked about. But within the atrium, there's an outpouching that's like a dead end in that chamber called the left atrial appendage. So you can imagine if you already have a lot of stagnant blood and then you have a dead end, well, things get stuck in the dead end. So clots are more likely to form in the dead end. That dead end is called the left atrial appendage, okay, like an arm, like sticking out. Well, it turns out that 90% of the clots that happen in atrial fibrillation are hiding in the appendage. They're forming in the appendage. So Watchmen and other devices that are in the pipeline, something called Amulet, which is a competitor that will be coming out later this year, we believe. Basically, they look at that dead end and then they plug it so that in the main chamber, you don't see the dead end anymore, okay? By doing that, no clots can go in there and they can't stay in there and they can't come out and go to the brain. So that procedure has revolutionized atrial fibrillation care because some people can't be on blood thinners. So if you can't be on a blood thinner, well, then all of a sudden your risk is high and you either have a choice of just living with that risk or taking the risk of being on blood thinners and bleeding. Most people who are not on blood thinners despite atrial fibrillation because they had a massive bleed somewhere. So if you stop that, then there is this device that goes in up through the leg to the right side of the heart. It goes right through the atrial septum through a needle, which we do. It sounds dangerous, but it's not so bad. And then on the left side, we then deploy this device that walls off that appendage. So we do that. We probably do 4 a month at Westchester Medical Center. I co-direct that program. And it's worked really well because once you have that device in, we keep you on blood thinners for about 90 days. And then if everything looks like it's healed, we can stop the blood thinners and your risk of stroke and bleeding goes down to normal, to almost as if you're on the blood thinner. So that's a good procedure. The other procedure we do for stroke in young people is something called PFO closure. So young people may have a hole in their heart called a PFO. And even though it's very common, some people have blood clots in their legs that come up to the heart and they can go through this trap door called a PFO. And then if it gets to the left side, it can go up to the brain. So if we find that in a young person defined as age less than 65 in the clinical trials, closing the hole after a stroke reduces your risk of a second stroke by 90%. So that's a huge improvement. I've been doing this for about 15, 20 years. I've done over 300 of them. It's a very safe procedure these days. We can do them in about a half an hour. The patients are awake. But again, it's all about choosing the right patient. So that would be somebody who has a PFO, has a stroke, is young, and we can't find any other reason for the stroke. We fix the hole, okay? And that has kind of come back. It's been very, very popular now because the data is very strong that it reduces stroke. So again, when you look at stroke management, there's prevention with risk factors, there's prevention with blood thinners, there's treatment, as I mentioned, and there's also prevention with devices. And those are the two main devices to prevent stroke.
I think that was our last one.
Was that the last question?
Yes, it was.
I think that's good because we're at 7:55. So I want to thank you, Stavroula, and the Nassau County Medical Society for inviting me. I think these types of conversations, when we talk about just bread and butter cardiology, is important. And most cardiologists don't have the time to do that as much. So I want to thank you for inviting me.
Thank you for doing this for us. I think it's important, not only because it's Heart Health Month, February, it should be all year. Right. So thank you again. And this will be available to everybody who wants to hear it again, and we'll make it available to everybody else who isn't available. And we will be sending out Dr. Nadeau's information with a follow-up survey after this webinar.
Okay,
thank you.
Have a good night, everybody.
Have a good night.